everyone. It is so good to see you all. Before we really get going, I actually was going to ask Representative Madaro, if who's the chair of the Joint Committee on Mental Health, Substance Use, and Recovery, if you'd like to kick us off on what we all have agreed is a very bitterly cold morning.
Certainly, Mary. Yes, it is cold, but glad we could be together, at least virtually. Good morning. Again, my name is Adrian Madaro. I'm the state representative for the 1st Suffolk District, which is East Boston. Also the House Chair of the Joint Committee on Mental Health, Substance Use, and Recovery. Happy to be with you all today for part 4 in the Building the Buffering series provided by the Massachusetts Society for the Prevention of Cruelty to Children. Mary, I want to thank you and your team for allowing me to join you today and for your incredibly impactful work on behalf of children in the Commonwealth. Also want to make sure I recognize my fellow chair of the Committee on Mental Health, Substance Use, and Recovery, Senator Julian Cyr, who also sponsored today's briefing, as well as the chairs of the Joint Committee on Children, Families, and Persons with Disabilities, Representative Mike Finn and Senator Adam Gomez, who you will hear from shortly. Experiencing childhood trauma can lead to long-term mental health risks. These risks are exacerbated when the appropriate care isn't provided. To make matters worse, it is often this already vulnerable population of children and adolescents that encounter barriers and access issues. To understand appropriate care and treatment for childhood trauma, 2 models of support must be addressed. The first being evidence-informed and the second being evidence-based treatment. This training session will discuss these treatment methods and provide information for services available in the Commonwealth. I want to thank you all for your participation and engagement on this critical issue. I look forward to learning more with you all. And once again, I want to thank the Mass Society for the Prevention of Cruelty to Children for hosting today's briefing and for all the work that you do. Thank you.
Thank you very much, Representative. Very much appreciated. Senator Gomez, I know you have given us your weather report, but I don't know if you want to say a few formal words before we get going.
No, I'm just happy to be here in our 4th time around with this hearing. I know that throughout the year, we've been listening to a lot of substantial information in particular. So I really just happy to be here with all of you. I want to thank Rep. Madaro and also Julian Cyr, Senator Julian Cyr, and also my co-chair, Mike Finn, Representative Mike Finn, for being here once again with all of us. So that's all that I have. Thank you so much.
Terrific, terrific. Well, again, thank you. And I am Mary McKeown, the Executive Director of MSPCC. And I want to add my thanks to the chairs, Senator Gomez, Representative Finn, members of the Joint Committee on Children, Family, and Persons with Disabilities, and to the chairs, Senator Cyr and Representative Madaro of the Joint Committee on Mental Health, Substance Use, and Recovery for hosting us, and for your support in the interest of the legislature in helping children victimized by abuse and neglect to heal and thrive. Our goal for these sessions is to provide you with information on trauma, its impact on children and families in our child welfare system, and the critical tools to help recovery and help healing. And as we mentioned earlier, this is our 4th time coming together. Our earlier sessions provided an understanding of the ways that adverse childhood experiences, ACEs, toxic stress, and trauma can negatively impact a child's brain development, and how that harm can be mitigated through healthy, positive relationships with caregivers and with community support. We learned how early or ongoing trauma, alcohol, substance use, and mental illness may impact parenting by impairing a mom and dad's capacity to provide stability and to accurately read and respond to their child's needs. And in our last session, we heard about children in foster care and the role medication plays in healing and the benefits of psychotropic medications and its drawbacks. If you missed any of these sessions or simply need a refresh, please visit www.mspcc.org and watch it at your convenience. Today, we're going to build on our understanding of the impact of child abuse and trauma, and we will learn about the therapeutic tools and the science-backed techniques to help children heal through evidence-based approaches. Before we begin the session, let's pull up the slides, and I ask you to bear with me for a few reminders. Again, this series is part of our work to promote a better understanding of children in foster care and their needs. And Kat, you can go to the next slide, I think. All right, and go one more. Yeah, so MSPCC is part of a collaboration that, with the generous support of the Health Foundation of Central Massachusetts, is implementing an innovative program, Encompass, which supports and enhances supports for foster parents. Foster parents are loving caregivers, and with the right supports, they are the intervention to help kids heal from trauma. Encompass provides support from a skilled, trained peer, leading to stability and better outcomes for kids. Next slide, Kat. And this is just our great collaboration. I always feel fortunate you get to see my face, but it is really my team here from FACES and CASA, the Health Foundations, LUC, DCF, and MAF who really make this possible. A few more logistics. Please be sure you are muted when you are not speaking. And as Kat mentioned, we are recording the presentation. However, the questions and answers after the presentation will not be recorded. And speaking of questions, please use the chat if you have any during the course of the presentation. And now it's my pleasure to introduce today's presenter, Dr. Jessica Griffin. Dr. Griffin is a licensed psychologist and an associate professor of psychiatry and pediatrics at UMass Medical School. And she's also the executive director of the medical school's Child Trauma Training Center. Since 2012, when the center was created, and under Dr. Griffin's leadership, more than 36,000 professionals have been trained at the center in trauma, trauma-informed care, and trauma-sensitive practices. Welcome, Dr. Griffin. We look forward to today's presentation.
Thanks so much, Mary, and thank you, all of you, for having me here today. Again, my name is Jessica Griffin. I'm a psychologist at UMass. I've been there since 2006 and do all things child trauma related there. But I want to talk just very briefly about our program, because I want folks to please use us as a resource. So I'm the executive director of Lifeline for Kids, but Dr. Heather Forkey is my counterpart. She's the medical director, and I know you've heard from Dr. Forkey already, giving you a talk using probably her frozen metaphors throughout. And so I will weave in my own metaphors today. We're going to do a little cooking together as we go through the morning. But we do a lot of different activities and have programs at our center. What I'm going to be referencing though today, I'm going to talk about training, evidence-based treatment, and access issues related to children accessing evidence-based treatments. And we do a lot of other things. I won't go through the whole list here, but I want folks to please see us as a resource. We are a statewide trauma center housed out of the university. So a little history lesson. There is a lot of work that goes into rolling out evidence-based treatments locally, regionally, and statewide. We started our very first learning collaborative, and you'll learn what that is a little bit later on if you're not familiar with that, in trauma-focused cognitive behavioral therapy, starting back in 2006. And it was actually MSPCC was there, LUC was there, a lot of the same players were part of that initial rollout in TFCBT through a systems of care project. And then over the years, partnered with lots of other agencies and organizations to start to really spread dissemination of evidence-based treatments statewide. We have some funding from DMH, some funding from foundations, and federal funding through SAMHSA to expand our work through our center, as well as a number of other funded sites in Massachusetts, funded by the National Child Traumatic Stress Network. We partnered in 2011 with DCF to do what folks may remember as the Massachusetts Child Trauma Project, and did a large-scale training statewide in 3 different evidence-based treatments. So trauma-focused cognitive behavioral therapy, child-parent psychotherapy, and attachment regulation and self-competency, the ARC model. So you're going to hear about those 3 treatments later on today. But I have this slide up here just because I want folks to see that there's really been the step-wise way in which we've rolled out evidence-based treatments statewide. And we have learned so much along the way, made a number of missteps, but we've learned so much in what it really takes to implement and sustain evidence-based treatments. Okay, so why am I talking about evidence-based treatments or evidence-informed practices? So what's the difference between an evidence-informed practice versus something that's considered evidence-based? We really need both. At the end of the day, you think about an evidence-based treatment as the treatment we know that works. So if I have one of my children, I've got 3 kids, I've got a child who has a really bad ear infection or strep throat. I want to take them to the doctor, get the medication that is going to work the first time. I don't want to wait a year. I don't want my child to continue to suffer. I want to know that there's a treatment that has been demonstrated to work as quickly as possible to help him feel better. And so that's really the same sort of approach in the way that they've tested treatments for kids. The same way that they test medications like penicillin, for example, or other antibiotics that they might test. So what they do is these research studies called randomized controlled clinical trials, they compare treatment versus a treatment that they know to be effective or treatment as usual to some sort of control group. And then they measure the results over time. And they compare the 2 treatment groups as well as to a control and see if there were changes. So in order for a treatment to be considered an evidence-based treatment, it has to have undergone that same sort of scientific, rigorous research where they're doing these randomized controlled clinical trials. Now, the issue with those are they're very costly. Oftentimes they're supported by NIH studies or other types of NIH, NIMH, or large foundation money to support testing those particular treatments. And the problem with evidence-based treatments sometimes is there's either not they're not necessarily designed for the population we're really trying to focus on. And so evidence-informed practices are treatments that have not yet been tested through those randomized controlled clinical trials, but they're necessary in order for us to better serve kids. So for example, in all of the evidence-based treatments, by the way, at some point were evidence-informed practices. So grounded in science, but not yet tested. So for example, we've been piloting trauma-focused cognitive behavioral therapy with transition age youth. It's not considered an evidence-based treatment for transition age youth, but it's informed by the science right now. We know that there are things that work for certain age groups. It's not yet been tested for this age group, so it's considered an evidence-informed practice. So you need both, but at the end of the day, if you're going to make a choice, you really want to go with that evidence-based treatment. So that's what I'm here to talk about today. You can't, though, get to the treatment becoming evidence-based without it starting being evidence-informed. So hopefully that makes sense to this group. Happy to answer any questions about that later on. So one of the issues when we run into training in general and trying to help people really adopt evidence-based treatments there are some concerns that come up. And this is where I'm going to start to bring my own metaphors into things. We're starting with the German chef here. So one of the strong concerns that we hear from people is that, well, if you're doing this manualized approach, it's a cookbook approach to all kids, and you can't put all kids in the same box. And if you do these 3 ingredients and bake at 350 degrees, you're going to have a trauma-free kid. It doesn't work like that. And my hope is that by the end of my talk, you'll be able to understand that even though these treatments are manualized, they're very much able to be flexible and individualized to the child, the family, be culturally responsive. We make modifications for different groups based on what that child and family needs. And the other is the cookie cutter approach. Are you taking this cookie cutter approach to my child? All kids are unique, all families are unique. And why would you take this manualized approach and assume that that's going to work for every kid? All right, so for those who want to get more resources, I have links here for you. How do you find out more information about evidence-based treatments? And there are now hundreds of different evidence-based treatments that are trauma-related, evidence-based or evidence-informed practices. You can start with the National Child Traumatic Stress Network, which was established by Congress in 2000 to try to raise the standard of care for kids who've experienced trauma. You could start there. There's a whole list. You can find out lots of information about the different trauma-specific treatments. However, the Results First Clearinghouse database has taken a lot of these clearinghouses that we have for evidence-based treatments and pulled them into one space. And then they color code the different types of treatment, green, yellow, red, based on the level of evidence that they have for that. And we'll get into, is there an evidence base for X population? So a lot of really great information there. If you're familiar with NREP, which was part of SAMHSA, which was another clearinghouse, they stopped the funding for that in 2018. So all the information that was in that particular resource has been pulled into this Results First Clearinghouse database. So this would be the go-to place to go. And then the California Evidence-Based Clearinghouse is another great one, although that's been pulled under the one I just talked about. Okay. Now, I'm going to talk a lot about evidence-based treatments. I train in evidence-based treatments. I know that these treatments work. I've seen them. I practice them, but not every kid needs an evidence-based treatment. And we know that kids have lots of different protective factors that can influence how trauma impacts them. You heard that from Dr. Forkey. But if they have experienced trauma and they have symptoms related to that trauma, those are indications that an evidence-based treatment to help them heal from that trauma is warranted. So if you see a change in their functioning, there's been trauma, then we would suggest some type of evidence-based treatment for trauma. How do we know? Assessment is a really important part of that. I used to joke that I needed a t-shirt. Now in the virtual world, I can make one that says, if you don't ask, they won't tell you. So really we work really hard to train our clinicians and other professionals on how do you ask about trauma? How do you screen for that? How do you assess for that? And then once you screen and assess, do you then know what to do about it? So that's part of where we then come in on sort of the clinical side. So asking about trauma experiences, but also asking about trauma symptoms. Now I'm going to talk briefly here about what's called a learning collaborative or learning community model. So the evidence-based treatments that you're going to hear me talk about today, all of these are treatments that the training really needs to be done within what we call a learning collaborative or learning community model. You can't just pick up a textbook and read how to do that or attend a 2-hour lecture and then be able to practice in that particular treatment approach. And that's one of the reasons why evidence-based treatment training is costly. You're not just paying for the trainer's time, you're paying for clinician time to really get trained in these treatments to be able to have those really positive outcomes that we see. And so we've had a number of different learning collaboratives over the years that have been statewide initiatives funded through Defending Childhood Initiative, a lot of SAMHSA funding, Mass Children's Alliance. So there have been a number of statewide learning collaboratives. We've trained several thousand clinicians in various treatments over the years, including trauma-focused cognitive behavioral therapy, child-parent psychotherapy, and the ARC model. You'll hear about that. So it starts with the training, and that training depends on which treatment model you're looking at. That training can include a basic training, which is done over 2 to 3 days. Then there's typically a year or 18 months, depending on the treatment approach, of ongoing consultation. Sometimes there's an advanced training that is part of that as well. And a supervisor's track that's also built in there. And so there's a lot of training that happens around that first initial basic training. So clinicians will apply to be part of a learning community or learning collaborative. There's pre-work that goes into it, whether that's online, course they take or readings they have to do. Then they all come together for that basic training. Now we've been doing this all virtual and learned a lot that way as well. There's ongoing consultation groups for 6 to 18 months. There are a couple of models that will do twice monthly consultation so that you can do that in 6 months instead of a year, or it's a minimum of monthly consultation. And then there may have advanced training learning sessions. There are some EBPs, evidence-based practices, that require videotaping your sessions, having someone watching you behind a one-way mirror, or watching videotape sessions or audio tape sessions, and then ongoing supervision in that way. And then there are senior leader and supervisor tracks. And these, the learning community model, learning collaborative model is really informed by implementation science. So people who've studied how do you get uptake in communities of practice, how do you really get, if you're going to pour dollars into training people, how do you get it to stick? And so what they've found is that you really need to take this deeper approach. It's sort of that attend a training and then go practice the model isn't really going to have as much uptake as ongoing consultation and supervision. All right, so what are some components of trauma-informed treatment? Here's my cute little chef here on the screen. If you aren't able to access a evidence-based treatment, you want to at a minimum determine that that treatment is trauma-informed. So regardless of what the evidence-based treatment is, these are the components that you really want to make sure are included in that particular treatment. And so the treatments that I'm going to share with you today all include these different aspects. So screening, assessment, asking kids about trauma and their parents, building a strong therapeutic relationship. It doesn't matter what alphabet soup I'm going to train you in. If you're not able to establish a therapeutic relationship with kids and parents, then the treatment's not going to go anywhere. Psychoeducation about normal responses to trauma, that Johnny understands that, oh, gee, this is something that happens to lots of kids. There's nothing wrong with me. This is about what happened to me. There's nothing wrong with my brain or my body. In fact, it's responding exactly how we would expect it to based on what I've gone through. So providing that psychoeducation is key. Working with parents. You heard from Heather Forkey about how caregivers are so valuable in this approach, in trauma-informed approach, and really are the key. And we think about caregivers broadly. The treatments I'll be sharing with you have been utilized and have an evidence base in working with kids in foster care and working with an auntie in the caregiver role. I've done TFCBT with a minister, with a baseball coach in that caregiver role. So we think about that caregiver piece more broadly. Do they have knowledge of child development? That goes without saying. Emotional expression and regulation skills. Are they talking about feelings, helping kids manage feelings and manage anxiety? Are they teaching relaxation to bring down that hyperarousal, that stress response Heather talked about that happens in the body? Are they doing what we call cognitive processing or reframing, just helping kids think differently about their traumatic experiences? So the child who says, well, it was all my fault, I was sexually abused. We're working with them and doing techniques to try to challenge that thought that, of course, it's not their fault that happened. Trauma narration, trauma processing, trauma organization, whatever you call it. It's basically, do kids have an opportunity to tell their story about what happened to them? And that's one of the elements that is a really important part of doing trauma work. And last, but should be first on the list, is promoting safety. And I don't just mean physical safety. We will talk about safety plans as far as domestic violence, et cetera, but we're also thinking about psychological safety. So how are we helping kids feel more comfortable in their bodies and their environments? What are triggers and trauma reminders? And how are we helping to create environments at home and school and elsewhere in which they're feeling safer psychologically? All right, so here I'm just going to walk you through a couple of the different evidence-based treatments. These are just selected ones. I selected these based on a couple things, what's been disseminated in Massachusetts, what's available in Massachusetts, and some of the more popular evidence-based treatments. Sorry, here my analysis. Okay, so first I'm going to talk about trauma-focused cognitive behavioral therapy, and I will put out there my own bias in that I am a national TFCBT trainer. So I'm going to talk a little bit more about TFCBT, not because I'm a national trainer in TFCBT, but it is the treatment that we have the most clinicians trained in and the treatment that has the most evidence base that it works. That being said, it's also been around longest. It's had more opportunities to get more randomized controlled trials. We have RCTs in the Democratic Republic of Congo, in Japan. It's being done, spread globally here. And so it's been around longer. But there's been a number of clinicians trained in TFCBT in our state. So what is TFCBT? So it's a hybrid treatment model. It's not, I don't mean like a Prius. I mean, we're really pulling in trauma-sensitive interventions, family therapy, empowerment techniques, trauma-sensitive interventions for kids to create a model that we know that works with children. And as I mentioned before, this slide needs to be updated because there's been a lot more reach because of the pandemic. Some of the good things that came out of that, so we've been able to spread beyond this map, but it's been implemented all over the world. It is evidence-based. So it is the most rigorously tested treatment for kids ages 3 to 18. 3 is the youngest. 18, as I mentioned earlier, is what we have the RCTs that are going up to. We have been piloting it as an evidence-informed practice with our clinicians who've been trained in our various learning collaboratives. They're able to use it with youth up to age 25. We're getting some really great data coming back for that particular age group. So who's TFCBT appropriate for? Kids who have a trauma history, a known trauma history. It is not the right model for kids who we suspect there's been trauma, but we have no idea what that is. We need to have a known trauma history. They need to also have prominent trauma symptoms. So kids who had behavior problems that pre-existed the trauma would not necessarily be the best fit if they had behavior problems that were worsened by the trauma or were trauma related, can be very effective at addressing those. They do not need to meet criteria for post-traumatic stress disorder, but have some sort of trauma-related symptoms. Caregiver involvement is optimal. We work very closely with caregivers, parents, foster parents in the model. You can proceed in TFCBT without that caregiver component, but we work really hard to try to think creatively about who we could pull into that role. It can be done in a variety of different settings. And over the years, RCTs have been testing this in lots of different settings, whether it be home-based, residential, et cetera. So it can be done in a number of different settings, as you can see here, and can be applied to youth in foster care, kids with developmental disabilities or delays, complex trauma exposure, and lots of different cultural groups. And I can't even tell you how many languages it's been translated in, but we've got trainers, a new round of international trainers who are very busy translating and working with translators on our materials. So there've been lots of different groups there, and there are, it's tested with different groups, we then have modules that we can add to clinicians who've already been trained. So for example, there may have been clinicians who were trained in 2006. The model has evolved considerably since then. So we will try to bring them back for advanced trainings when we can on using the model with youth with developmental disabilities or delays, TFCBT with Latinx population, for example. So here are the components of TFCBT. All right, so we're going to do some more cooking together. So what I'm here to tell you is a recipe is necessary, but for those of you who like to cook, you know that you can mix it up a little bit, right? You can add a little bit of cinnamon here if it makes sense for that particular, your mood or that particular child. There are ways in which we are flexible with the treatment components. So we start with psychoeducation and parenting skills. That being said, most kids were actually going to start with the E in our practice acronym here. So we're actually going to move safety up to the beginning and start with safety. So instead of practice, it's E practice. But psychoeducation and parenting skills, parenting we do throughout treatment, relaxation and stress management, we're teaching those skills to turn that hyperarousal down. Affective expression and regulation, again, that's our fancy phrase for feelings. Cognitive coping, this is where we teach kids that how you think about a situation can impact how you feel, and how you feel can impact your behavior. And that by changing the way I think about a situation, I can actually change the way I feel and impact behavior as well. So that's where we teach things like the cognitive triangle, which Heather may have talked about, and lots of other skills. Then the trauma narrative development and processing. This is where children have the opportunity to tell their story about what happened to them, whether it's what it's been like living with a lot of community violence happening, my story about when I was sexually abused. For some kids, it's not just one trauma type, but lots of different chapters focused on different types of trauma that have happened. But we're doing this gradually. We're gradually desensitizing them to what's happened to them, not because we're going to undo the bad things that have happened to children, but we're helping them be able to cope with it, manage their distress, make meaning, and promote healing. In vivo gradual exposure is live exposure. So if kids have a particular fear, such as sleeping in their own bed, or they don't want to go to school anymore, we're working with them to come up with a hierarchy of feared stimuli, or in vivo desensitization plan, also known as baby steps, in order to help them do that thing that they fear the most. Conjoint parent-child sessions, we're bringing kids and their caregivers together for the child to share their story if they want to with their parent. There's a lot of prep work that goes into that particular piece. And then the last component is enhancing safety and future development. We're teaching lots of safety skills. We're also focusing on helping them do meaning making about what happened to them. What would I tell other children who experience domestic violence in their homes, etc. Okay. Tfcbt would not be appropriate for kids who are younger than 3, and frankly, not every 3-year-old is the best fit, or 4-year-old. It really depends on that child, and that's where we work with clinicians to try to determine which treatment might be the best fit. And then if they're actively suicidal, psychotic, or substance abusing so much that they can't stay sober in session, so for kids that are smoking weed in their adolescent, that we would not rule them out for TFCBT. It's when the substance misuse is so prominent that you're not able to do the work. And for kids who don't have symptoms, we would not put them through a full course of TFCBT. We might do something trauma-informed, but not TFCBT. All right, and then next on my list here is child-parent psychotherapy, which is a beautiful model for kids ages 0 to 6 that focuses on the parent-child dyad. So the client is actually the relationship. So the clinician is in the room with the parent and the child, and doing, noting, coaching, helping that caregiver be able to better support their child. And so again, it's a different approach because the relationship itself is the client. And it goes all the way up to age 6, but this is one of the models that we have for young children. So one of the issues that we've run into, and even in our referral data, kids in young children are waiting the longest oftentimes for services. Part of it is we just don't have enough people trained in the early child models. This is one of many early child models, but there aren't enough people trained. Child-parent psychotherapy is also costly to train in that it's not just the training that you're paying for, but also clinician time, because it's an 18-month learning collaborative with more, I think at least twice monthly consultation groups. So there's a lot more that goes into that. And yet it's so needed for young children. All right. And that the treatment length, the other part that drives up the cost, is that the length tends to be longer. So TFCBT, for example, can be done in 8 to 12 sessions. For kids who've experienced complex trauma, it's anywhere, we may have to double that up to 30 sessions. Child-parent psychotherapy tends to run around 52 sessions. Child and family traumatic stress intervention, CFTSI. We don't have a lot of CFTSI trained clinicians in Massachusetts, but there are pockets of clinicians who are trained in this particular model. And this is actually a model that's designed to prevent PTSD. So it's designed to be implemented immediately within the first 30 to 45 days after a traumatic event or a child's disclosure of a trauma. So it's to prevent onset of PTSD. It's a shorter intervention. It's 5 to 8 sessions. It may be a bridge to another treatment. So for example, trauma-focused CBT or the ARC model, it may be a bridge to that treatment as a brief intervention. And again, this is ages 7 to 18. Parent-child interaction therapy. So this is a really cool model that is highly specified, and this is a pretty step-by-step model, but it's done with live coaching sessions with the parent and the child, and through a bug in the ear receiver transmitter system that the clinician will use behind a mirror, and it goes anywhere from 12 to 20 sessions. It's really focused on the behaviors that the child is demonstrating and helping coach the caregiver on how to address those particular behaviors. It ranges from 12 to 20 sessions depending on how severe the symptoms are, how much the caregiver is engaged, etc. PCIT also has a pretty extensive training requirements. This is one of the models that does have videotape sessions that are being coded and rated by supervisors or consultants. And then lastly, the ARC model. So ARC is still considered an evidence-informed practice because it doesn't have those randomized controlled clinical trials yet. They're in progress and hopefully they'll be out here very soon. We'll have some more data on ARC, but it was developed right here. Margaret Blaustein is in Massachusetts. Christine Kenneberg is, it should be Christine, there should be an E on the end of Christine's name, is in Connecticut, and Margaret and Christine developed the ARC model to really focus on addressing complex trauma. So kids have experienced multiple traumatic events over time. It's a very individualized model in which you can, it focuses very heavily on attachment, but it's individualized based on each child's strengths as well as what they're really struggling with. To find out more about ARC, I have the website. I have the website on each of these slides for folks if you want to find out more about each of the models. Okay, so how do we determine, I'm looking at my time here, how do we determine which evidence-based treatment? There's a lot that goes into determining this. There are child factors that play into it, type of symptoms that they may have, their age, developmental level, what they're really struggling with, the timeline of the symptoms. There are parent factors, how much is the parent going to be involved in the treatment, the parent's own level of distress, perhaps related to that trauma. And then there's environmental factors. So that could be stability of the child's placement, what's the case plan and goal, etc. The other thing that drives which evidence-based treatment is just frankly, what's available in the area that the child is in. And we see this firsthand through our access program that we have at UMass called Link Kid, which I'll talk about here in a moment, where we've referred kids to all sorts of evidence-based treatments over the years. So in order to determine if a therapist, so even if they're not trained in an evidence-based treatment, there are questions that people and parents and others can ask if they are providing trauma-specific or trauma-informed therapy. Are they familiar with the models? Can they give a rationale for why they haven't been trained in it? And what their approach is, what's a typical course of therapy look like for them? Can they describe, well, what are your essential elements of treatment approach? You want to make sure that if they're not doing something evidence-based, that at least it is trauma-informed with a lot of those same components that I talked about earlier on. So now I'm going to talk about the access issues and can speak firsthand about these issues that we've really tried to focus on these through our center and in partnership with lots of different programs. So part of it is just availability in the service area, who's been trained in what model, who speaks certain languages. So we had one of the nice things we've had about our access program we have called Link Kid is we're able to look at who's waiting the longest. So we can then take that back to those who may be able to help support these efforts and say, listen, at one point we had children in Spanish speaking families were waiting the longest for services. We were then able to go back and outreach to providers who are bilingual, multilingual, to get training at no cost in trauma-focused CBT. So we brought in trainers to provide that training in Spanish for folks to just try to increase the workforce. The workforce turnover is not new to anyone here. The turnover is extraordinary the last 2 years. Even before that, when we did the Massachusetts Child Trauma Project, we found a third of our clinicians trained in evidence-based treatments turned over in each training year. So you're training, you might train 100 people, but at the end of that training, plan on having about a third of those drop out for lots of different reasons. Either they change agencies, or they're really good and they're promoted into more supervisory positions. And so they're doing less direct service. The costs also play into this. It's not just the training, it's the clinician time, it's the additional time to do some of the assessment tools that are part of the models. And then lastly, it's the moral distress that those of us who do this work and you all run into. Who's a bigger priority? So I was at a meeting recently and was asked to do some brainstorming around kids who fall under commercially sexually exploited children. And the ask was, well, can we have clinicians hold slots specifically for this population? The problem is I can hold slots for this population, but what am I going to tell the 4-year-old who just disclosed X, Y, and Z happened to him? And so it's this moral distress we all run into and sort of whose issues are bigger. One of the ways we try to address the access issues and have been able to some degree is through Link Kid, which I've mentioned here already. And this was a system we developed in 2012. We piloted in Worcester and Hampden counties, and to improve access to treatment. So the story behind it is I had my second child and was still not sleeping through the night. And there was one night I woke up and just could not sleep around this access issue because I had trained a bunch of clinicians down the road at another agency. We were working, I was working with one group and they had about 80 kids on their wait list, but I knew there were 20 clinicians down the street who had openings because I had just trained them. They were wanting referrals. And so what we ended up piloting was this Link Kid referral system. And at the time we surveyed folks across the state, found that kids were waiting on average of 6 to 9 months for treatment, with wait lists as long as up to a year or more for their very first appointment. And so we developed Link Kid, housed at UMass, where it's a centralized referral system. We have provided referrals now successfully to over 5,000 children in the Commonwealth, and so have learned a lot over the years on how to do a referral system and what this actually looks like. So we have clinicians who take the calls, who've been trained in the various evidence-based practices. They may not practice them themselves, but we require them to understand the treatment model so they can make the best referral. Anyone can call us, whether it's a parent, a pediatrician. We've even had older youth call us to make referrals to treatment. We provide a lot of family engagement strategies during those calls, trying to support them during that waiting period. So we've not been able to eradicate wait times. What we've been able to do, though, is reduce those wait times significantly for families. We've found that we've been more successful with kids in foster care in particular, who may move from home to home, which then means that their clinician may be changing over. We still can hold those kids even if they're moving from place to place. It's not easy to do, but we're able to do that, to try to ensure that they're able to receive treatment, even if their placement may not be stable at that time. All right, and then clinicians are part of our Link Kid database. We've got hundreds and hundreds of clinicians as part of this, but they have to have been trained through a learning community or learning collaborative model like I talked about before. Very briefly here, and then I'll open it up for questions just so you can see the numbers that we're seeing. So of the over 5,000 kids who've been referred, our wait times now are averaging 40 to 52 days. That number ticks up. It ticks up for a couple reasons. One is just a data issue because there are kids that we can't find that are still on our wait list. So we're having to sort of clean up that data. So it's around 40 to 52. There are some families in which the wait is much, has decreased significantly from that. The average number of types of trauma in the children who've come through our center is 4 to 5. So it's not just one, house fire that happened on one day, or just domestic violence here. It is a child who's experienced parental substance misuse, traumatic grief, physical abuse, sexual abuse, and a house fire. So 4 to 5 types. 40% of our referrals, and this is all of our referrals, involve parental substance misuse. When we look at that data of those 40% who have parental substance misuse, and we compare those who have parental substance misuse to those who don't, they have an average of 2 more types of trauma on top of that. So it's important for us to keep in mind, especially for policymakers, when we're thinking about the interplay between substance misuse and trauma. As I mentioned before, and spent a little more time on TFCBT, about 60% of our referrals are to TFCBT providers, just because we have more providers trained in those, and the wait times tend to be shorter. ARC is the second most referred to, because we have more clinicians trained in the ARC model, and then CPP, followed by other evidence-based treatments. And then I have this, I'm not going to go through the numbers. The red is 2021. Just to highlight how significant we know the pandemic has impacted, as this group knows, children's mental health. The trauma coming in, the referrals coming in are through the roof. We've lost funding for our federal funding to support Link Kid and have not increased our staff, but we're still taking the calls and making these referrals. And as you can see here, compared to 2019 and 2020, our calls are continuing to stay really high. And this is, if we compare the quarters, just looking at October to December quarters, you can see they're similar to the chart you saw before. County-wise, so we are housed in Worcester County, and I think have our strongest relationships there, which is why we have a large percentage of Worcester County folks, followed by Middlesex and Suffolk, Franklin, and others. Part of it's just a marketing issue and outreach issue too. And this is that same October to December breakdown. All right, I'm going to stop talking here. Resources for the training, please feel free to use me as a resource as well. I'm happy to take questions, but I'm happy to also talk offline if anybody has other questions about evidence-based treatments or anything else.
Dr. Griffin, thank you. That was terrific. And as the executive director of MSPCC, the Massachusetts Society for Prevention of Cruelty to Children, I have to tell you, people often ask, what can we do? And when you listen to this presentation, it's so important for our friends in the legislature to really understand there are interventions that work. And by investing in these, it really is prevention, because we're going to change the outcomes for these kids. And so that's why it is so important that we understand it, that we think about it, and that we ask the very first question, Dr. Griffin, which is, what can legislators do to make EBTs and EIPs more available for families?
I think it comes down to advocating for funding for learning collaboratives to get the providers trained. Right, so you've got to get your workforce trained, and with the expectation that you're going to have that turnover. You're not going to be able to keep every clinician. But the other piece to think about is, does it make sense? And some states have gone in this direction for higher reimbursement rates for evidence-based treatments that actually reimburse for the time that it takes to use those treatments. So for example, and this can look a lot of different ways. So I do a lot of consultation and work in Maine, and they now have, as part of their DHHS service plan, so their equivalent of DCF, trauma-focused CBT and other evidence-based treatments on that. So they're now, that state has been funding learning collaboratives specifically in those different models. Their clinicians now, as part of getting certified, can then receive higher reimbursement rates for providing those services. So I think that's part of it, is really the advocacy around the funding piece, and then really thinking through the access issues we now have, and things are moving and changing with the behavioral health roadmap here in Massachusetts. So I talked a lot about Link Kid, how that will be impacted, and if that falls under, we're still trying to work all that out and figure that out. So I don't want to overpromise Link Kid either here if things are changing, and we're going to have this helpline now. But there are also ways in which we could be, I think that it really comes to the funding piece around the learning collaboratives, but also when it comes down to the clinician level too, because it does require extensive time for that clinician and that mental health agency.
I think you raise a really good point, because when we talk about rates, people sort of are looking at rates at the end game. What does it cost to do that service? But the idea that it's a whole picture. We need to create a rate that supports that level of training and ultimate turnover. I agree with you. You mentioned clinicians and just the turnover. And today's Boston Globe has a story about just how the workforce issues that as an industry mental health is facing right now, and that there aren't enough clinicians out there to deal with the crisis that we're seeing among kids. You've referenced it a few times, but can you make maybe the stronger connection between the learning collaboratives and the impact it has on clinicians and staff retention? I just think that's sort of interesting.
Sure, Marion. I think we were chatting about this offline beforehand. So we found those learning collaboratives really were informed by implementation science. So how do I get a treatment to stick? One of the things that our clinicians need, though, is to feel supported, to feel like they're part of a community of practice, that my colleague has my back, which is something that's necessary with the amount of secondary traumatic stress or vicarious traumatization. The impact on you as a clinician in doing this work. When I have a really difficult Tfcbt session, for example, or hear a story, I may call Heather and say, oh my gosh, you're not going to believe what you need to have, that supportive community. And so you don't feel like you're doing this in isolation. And, one of the things I think we're starting to talk more about is the impact on mental health providers in trying to, the moral distress we've all had and seeing the suffering and what can we do about it? What's wonderful though, is I have so many clinicians, junior clinicians, just straight out of grad school, who will say, I feel so empowered. I know what to do. I feel like I have a roadmap on how to help this child. And one of the most rewarding things is hearing that, oh my gosh, Jess, it worked, and he's feeling better, and he's sleeping through the night. And it's so the treatments work. But clinicians really need to learn those within that supportive community of practice, and that's where you're going to get the uptake and where the resources are going to last the longest.
Absolutely. Yep. We've got to invest in our clinicians. They are the backbone. One last question before we close. And again, it starts with, as lawmakers, is there a way to determine what kind of model is being presented when we meet with different organizations? What are we looking for that would indicate an organization or a program delivers evidence-based services?
So they need to say that they're doing evidence-based services and treatments, and then ask, well, tell me which ones. Have your clinicians undergone learning communities? Have the supervisors and senior leaders been trained? Because that's really important, or at least trained enough to know how to support that model in their organization. On one of the slides I referenced earlier, the components of trauma-informed treatment, are they providing those things in their organization, from screening to promoting safety, working with parents, and so on. So I think, asking the questions, not being afraid to ask those questions, have them talk about what are the evidence-based treatments they've been trained in, when were those learning collaboratives, was it just something they did online versus did they actually participate in one of these larger learning communities. And there have been, Mary, I did want to add this back to I think the first question, there have been cost studies for example, that have looked at pouring dollars into evidence-based treatments and then showing that they've actually been able to increase placement stability, decrease the amount of time spent in stepped up care, residential inpatient care, by investing earlier in some of the evidence-based treatments. So folks are interested in any of that. We did a smaller cost study in our Massachusetts Child Trauma Project too, looking at the different models as well.
Great, great. Well, thank you. Thank you very much, Dr. Griffin, for not only today's presentation, but really your professional commitment to provide these and get these services here in Massachusetts for the kids and families in DCF care and across the state. It really is so important. And the work that you do today and have been doing for the last 10, 15 years has really made a difference. So thank you very, very much. And thank you to all of you for joining us again today. We appreciate your giving us the time, the good questions, and we look forward to seeing you at our next one more session, Kat? One more session, but I don't know the date. We'll have to get it out to you guys. So thank you very much and stay warm. Have a good day.